Welcome to this series of interviews with the giants of cardiothoracic surgery. My name's Joel Dunning and I'm delighted to be here with Professor Tom D'Amico here in the beautiful Cambridge VATS Symposium, and what a fantastic location it is for a conference. Professor D'Amico, you need very little introduction, but you are a professor of thoracic surgery at Duke University in Durham in the USA, and you've taught a vast number of people over the years, and you were one of the very first people in VATS lobectomy. So there's so many things I would love to talk to you about, but first, perhaps by way of introduction, how did you start VATS lobectomy in your initial experience?
Well, we started with the intent of making the operation that we were using less and less invasive. And when I finished training, I would not have thought that a VATS lobectomy was really going to be successful back in 1996. Started using a small anterior incision to do the operation open, learned to put a scope in to make the visualization better, and really the operation just grew from there. So there never was a third port. We started with a small anterior incision and a camera to improve visualization rather than trying to look into a small hole, then made the incision smaller and smaller until we settled that 4.5 centimeters would be enough. And then just experimented with where the two incisions would have to be to make essentially every operation successful without a third incision. In my early experience with VATS doing wedge resections or biopsies, we always use 3 incisions. That's how we were taught. It's a triangulation approach, which of course in retrospect makes no sense. But I hated the posterior incision anyway because it caused the most pain. So I was happy not to use it and develop a 2-port incision, which is what we use on most of our patients now.
And now you've sort of developed that 2-port incision, and you maybe coined it the sort of modified uniportal incision, that second port goes in the same space, is that right?
Yes, so we've moved the camera incision more anterior, and instead of being in the 7th or 8th space, we just put it in the 5th space, tunneled just a little bit. It's the incision in which a 20 or 24 French chest tube will go, so it's easily usable for that. And in my experience and in training residents, it is an easier setup to have an assistant, to have a proctor, and have a trainee do a procedure with a dedicated port incision for 3, 4, 5 instruments if you want, but the camera's separate to be managed by someone else.
So one of the key advantages is training and helping your juniors to do it. Would you say that's one of the real advantages of your setup?
Yes. Our technique has modified over time. I'm certainly not doing the same operation I did in 1999 when I started. And each modification really was based on, is this an easier, better, more efficient way to do the operation? And is it trainable? You know, you watch some procedures and they're beautiful. And certain operations are extraordinary. But it doesn't mean you can teach residents, trainees, fellows, registrars that technique. And so each time I've made fundamental changes, usually minor, it's based on efficiency of the operation and the ability to teach it to other people.
And would you say that's the absolute key of what makes a great VATS lobectomy? It's got to be teachable and reproducible, and it's got to do exactly what open surgeons would do.
Exactly, and I think that's why there are many people that have come to Duke not doing the operation and either spent just a couple days or come to a course or spend a few months and leave Duke knowing how to do the operation because it's fundamentally reproducible.
And would that be the way if anybody was watching this video and they had a 3-port or 4-port approach to literally come to yourself or watch the videos? How would someone learn your technique?
Certainly, I would recommend come to one of our courses. We give courses in North America, in Asia. I've given courses in Europe. Or come to Duke and watch us. We have a trainer that allows you to experiment with where you would put your incisions. And I think that fewer incisions is probably better. So if you're using a 4-port technique with one of the incisions posteriorly, I think it's worthwhile looking into losing that, at least that 4th posterior incision.
And with those small number of incisions you've got, how do you manage pain? Do you need extrapleural catheters, or obviously I imagine you don't use epidurals anymore? How do you manage pain?
So that's a good question. We prospectively look at each patient and decide, are they going to be the median or less in terms of discharge, or the median or just above the median and greater in terms of discharge. So if I'm doing a VATS by lobectomy on an 83-year-old, they're not going home on day 3 probably. And they might benefit more from having an epidural than if I operated on a 42-year-old person with, a 2-centimeter ground glass opacity. They're going home on day 2. So an epidural would impede the progress of a patient going home on day 2, but it would probably get a patient more functional in terms of respiratory mechanics if it's a more extended procedure, or if they're frail, elderly, poor pulmonary function. So we use epidurals in patients we think are going to stay 4 days, and use liberal use of Marcaine intercostal blocks, etc., on the younger patients, or patients that are predicted to go home at the median, which is 3 days or earlier.
That's a very interesting approach, the sort of tailored approach to patient, to selecting what you do in the operation. So that's certainly not something we hear all the time, is it? Tailoring to the patient.
No, and the other aspect is I want the anesthesia team to do enough epidural so that when I need it, when I do a VATS hybrid chest wall resection, you need an epidural for that. I mean, the patients are going to benefit from that. So we want a unit that is used to epidurals, teams that follow epidurals carefully, wisely, don't give them extra fluid just because their blood pressure is a little low on day 1. So the team stays facile with epidurals. It's the benefit of the patients that get it, and then it's the true benefit of the patients that absolutely need it, the VATS, chest wall resections, etc.
Yeah. So let's talk a little bit about extended resections. I'm what I might call a baby VATS surgeon. I've never done a chest wall resection. I've watched one of your fabulous videos on the internet recently, a total lung sparing left main bronchus resection. Absolutely amazing. I mean, maybe talk us through that operation, how that came about, and is that a reproducible procedure?
Sure. It was an interesting case, and that was the first. That was the index case, and we've done 2 since. It's rare because the tumor has to be in just the right location so that you get negative margins and still be able to reconstruct main bronchus to main bronchus. They've all been on the left because the bronchus is larger. I'm about to do one in the middle lobe that probably will end up being a middle lobe sleeve rather than a true bronchial sleeve resection. But it started with our philosophy really in the early 2000s that just start every case as a VATS. Even if you don't think you're going to be able to finish a case thoracoscopically, you don't lose any time. If you look at the chapters that have been written about VATS lobectomy over time, they contradict each other in a temporal arrangement. So the early chapters, adhesions are a contraindication, preoperative therapy is a contraindication, visible endobronchial tumor is a contraindication. It goes on. And then now if you read the chapters or papers or talk to people, almost nothing really is a true contraindication. In our unit, that started because we would just put a scope in, start every case thoracoscopically. If you hit a point in the operation that you couldn't proceed anymore, or realized you couldn't do the same operation thoracoscopically that you would do open, then you convert. And that's how we started doing sleeves. We'd get to the point where it would start to go together, and if the anastomosis was facile, we would finish it. If it wasn't, we would open. Same for pneumonectomy, same for some of the extended resections. So this particular patient with, I think it was mucoepidermoid carcinoma, the tumor was right in the correct location. We started posteriorly. We know how to get around the bronchus. We know how to cut a bronchus. And then you have to be creative about how you put it back together through a 2-centimeter anterior incision, and it was fine.
It's absolutely fantastic, a great video. And chest wall resection, I suppose it's the same thing. Is it put a scope in, see how far you can get? How do you actually cut the ribs from inside?
We've done it a couple of ways, depending on whether it's an apical tumor, superior sulcus, or something similar. We use a counter incision posterior to the scapula. If it's more anterior, you can get conventional rib cutters in and do the entire operation thoracoscopically through one anterior incision. Especially if it's truly anterior, you make the incision over the ribs, cut the ribs, drop it in, and then do the lobectomy. That's relatively rare. We haven't used the technique of using a burr or drill to get to the top of the apex without making a counter incision. So all of the superior sulcus tumors, or ribs 2, 3, and 4, I've done with just a small 7 or 8 centimeter counter incision parallel to the scapula, cut down on the ribs, divide the ribs with a standard rib cutter, disarticulate the ribs posteriorly, drop the chest wall back into the chest, and then take it out.
Wow, you make it sound so easy. That's great. I just love to see that. And so I suppose let's talk about a few other things. The difficult thing I always struggle with is N2 disease. I mean, what's your philosophy of N2 disease at Duke?
Well, this again started from a philosophy of starting all the cases minimally invasively. There was a cancer and leukemia group B trial, CLGB, for VATS restaging. And the goal was to take patients that needed induction therapy that were N2 and determine the efficacy of restaging with VATS. What percentage of patients could be effectively restaged, defined as getting 3 lymph node stations that were negative, including the one that was positive pre-op, and doing what a redo mediastinoscopy would have done. And we learned by doing that, you were doing a VATS mediastinal lymph node dissection. That's really what you were doing. And handing them to the pathologist, and then you would decide to go on and do the lobectomy or not. Well, once you've done the MLND, the vessels are there. You can say, well, why should I open now? You know, this contraindication that had always prohibited us from doing this operation was now gone, just simply because we'd done the lymph nodes. But it also tells you when you do the lymph nodes, this isn't a case I want to do minimally invasive. It's a case that we'll do open. Our policy is that if patients aren't significantly downstage with induction chemotherapy, in other words, the frozen section is persistently grossly positive, we don't proceed with that operation. But patients, I think, tolerate the VATS lymphadenectomy fine, even if they're not resectable. They can start radiation therapy within a week of that surgery. And so the VATS still provides progress to their ultimate therapy.
Right, so a positive N2, downstage them, go back in at the end and take out their N2 nodes. If they're negative, you'd carry on. If there's a positive N2, stop there.
Yes,
That's right.
but I would qualify negative and positive as relative, not absolute, not black and white, not on and off. So if someone has considerable involvement of a single station, and then on VATS restaging, the pathologist says, few cancer cells present. If the patient is operable with a lobectomy, I would still probably proceed. That demonstrates enough downstaging. And we don't use radiation therapy preoperatively. So if there is significant downstaging, even if it's not 100% downstaging, I still will proceed with a lobectomy. If it looks like it would be a pneumonectomy, if it's multiple stage disease, if it's an 80-plus-year-old patient, it would probably be less likely that I would proceed.
Yeah, that sounds very, very sensible. And just finally, do you have a program of routine CT surveillance of people to try a sort of a surveillance program? So is that prevalent at Duke?
It is. We have a separate screening program. We're one of the few centers that started as soon as the New England Journal trial was completed, even before the publication, of starting a screening program. And there are several in the United States. It hasn't taken hold in Europe yet. I think they're still waiting for the Nelson trial. But our surveillance is, again, tailored to the patient. If they get preoperative or postoperative chemotherapy, CT scans every 3 months for 2 years, and then every 6 or 12 months. If they're early stage patients, every 6 months for 1 or 2 years, and then annually. If their annual CT scan after 3 or 4 years is negative, we'll switch to low dose and proceed with low dose indefinitely, and then go to 18 months and 24 months if they're 5, 8, 10 years out.
Great. Well, it sounds like a fabulous program in Duke. I know you've done thousands of VATS lobectomies and taught so many people around the world. It's been a real pleasure to see all your videos and listen to your multiple talks, and I hope I listen to many more over the years. So for myself, Joel Dunning, and everyone at CTSNet, I'd just like to say thank you very much.
Thank you, Joel. My pleasure.
Thank you.